The holidays have begun. Winter is here, and so are the respiratory viruses. Welcome to the Urgent Care Association Solution on Demand webinar brought to you by HealthTrack RX. Today we'll be discussing some interesting patient cases and the role of multiplex rapid PCR in optimizing clinical decision-making in the urgent care center during these winter months. Respiratory tract infections can be caused by viruses, bacteria, and they're more common during these winter months and can present with similar symptoms that can cause clinical confusion and make patients really difficult to diagnose and treat. I'm your moderator, Ben Favre. To work through these cases today, we're joined by two experts in molecular infectious disease diagnostics in the urgent care setting. First, we have Dr. Janie French, who is the medical science liaison at HealthTracks and a clinical microbiologist. And we also have Dr. Stephen Goldberg, who is an urgent care practitioner at University of Louisville Health, most importantly, and he's also has a very important job as Chief Medical Officer at HealthTrack RX. Dr. Goldberg, as we jump into things, I'm interested to understand from a clinician's viewpoint, what do you focus on in dealing with the challenging patients that you see in the urgent care center this time of year?
Well, Ben, I'm excited to discuss these cases and cases that are occurring at this time. As an urgent care clinician, I found it helpful to apply principles of evidence-based practice, case by case by case, so that drives consistent operating by the clinician. That said, each case still has to be considered individually, and we'll show how that's so important on the cases we discussed today.
Excellent. Let's move on to our next case. Here we have a 10-year-old with a sore throat and swollen tonsils of 1-day duration. Patient history is unremarkable, fever of 102, you have tonsillar exudate, and another case with a negative point of care test. Dr. Goldberg, my little man here has a sore throat. He was up all night, doesn't feel good. Help us out.
The good thing about growing up is you forget what it's like to have swollen tonsils and exudate. It is miserable.
Yeah.
And it's such a common occurrence in the urgent care clinic. Just one point I'll make about tonsillar exudate. Tonsillar exudate doesn't equal group A strep. It's an inflammatory response. Yes, it can be associated with a strep throat, but it also could be associated with mononucleosis and viral pharyngitis. And yes, the appearance of that exudate can differ, but it's not always pathognomonic. But throat swelling, enlarged tonsils, exudate, just absolutely unpleasant. Add on top of that a fever of 102. What I'm considering for this young client is what is the cause of that oropharyngeal discomfort, oropharyngeal swelling, and do I need additional diagnostic testing now? Or do I do additional for the morning and then guide treatment based on that? What we see here is that the point of care testing was negative.
Thank you. And I'm telling you, this is the exact case my daughter had just this week. So I know exactly how much pain you're talking about. Janie, when this young gentleman or my daughter comes into the clinic with the sore throat, speed matters, right? They're hurting just like the young gentleman with the ear infection. What are the diagnostic options and what pathogens do we need to suspect?
With group A strep and strep throat, what we are trying to prevent is rheumatic fever. Rheumatic fever is most common in children over 3 years of age, but especially in those 5 to 15 years old. This patient is going to fit right into that category that is going to be most at risk. And we have a few different diagnostic techniques available to us because it's going to be challenging to distinguish viral and bacterial infections clinically. They may have very similar characteristics and testing is often recommended. So what options present to you? Many clinics will utilize rapid antigen tests for group A strep, as this is going to be a quick tool. And unlike many of the viral rapid antigen tests, group A strep tests tend to have better sensitivity and specificity than viral tests because circulation of group A strep is pretty consistent throughout the year. So the positive and negative predictive values don't change as widely as the seasonality changes. But in these cases where you get a negative rapid antigen test, it's often recommended for children to do additional send-out testing. And in those cases, you'll primarily utilize one of two options, either a throat culture, which is specifically going to look for Streptococcus species, or PCR. And this is going to allow you to definitively identify whether there's also maybe a respiratory virus associated with that. And that identification, if it is viral pharyngitis, can often give the patient peace of mind of why an antibiotic may not be indicated. Different options there with different advantages.
And Ben, what I
Excellent.
would add, based on this child's profile, can we try to use evidence-based practice? We try to use clinical rules. I think a Centaur score is helpful to consider decision-making. You have to consider elements such as the AIDS, exudates on the tonsils. Do they have swollen cervical lymph nodes? Is there a high fever? This child directionally would be leaning to a higher Centaur score. So the negative point of care testing is not consistent with that. Frankly, it's a bit confounding. And yes, the Centaur score can be variable. So I'm very concerned about group A strep in this child, even though the point of care testing was negative.
What y'all are saying is really resonating here. A comment that just came in: tonsillar exudate does not equal group A strep. You're preaching to the choir here, Janie and Dr. Goldberg. Well done. So Dr. Goldberg, in this patient, what's your treatment plan and how are we going to move forward?
Again, people will differ. Some would make a therapy decision based on the information we have here, and they wouldn't be wrong. My preference is to try to get a definitive diagnosis that I have high confidence in. I feel I can do that in this case because we're seeing the child within day one of symptoms. While I'm concerned about group A strep, as Dr. French said, what I'm trying to prevent is a valve infection or post-streptococcal glomerular nephritis. If I get that treatment going within 3 days, I'm going to be okay. This child's in within 1 day of symptoms. So this child's not toxic appearing. Guardian got him in, or parent, within 1 day after symptoms onset. So the inference is that they've got tight care of their children. I have confidence they won't be lost to follow-up. So given all of the above, I'll wait for a next morning definitive result before starting the therapy.
Thank you, Dr. Goldberg. With that, let's move to our next audience survey question. For pharyngitis, do you perform rapid antigen tests or skip straight to more sensitive culture/PCR? I always use rapid antigen tests before deciding to send out. I skip the rapid antigen test due to the lower sensitivity. I make decisions on antigen test results only. And while we wait to get some answers back, Dr. Goldberg, if this patient had presented on day 3 of symptoms, how would that change your thought process?
Again, going back, trying to drive evidence-based practice, the clinical exam, physical exam, Centaur score look consistent with group A strep. The point of care testing was negative. I have to make a choice. I'm going to go with my clinical exam finding. 3 days, I'm concerned about endocarditis, post-streptococcal glomerulonephritis. I would have started the antibiotic in that case. Still gone and gotten the definitive testing, but would have started the therapy.
And Janie, we have an audience question here. What's the clinical benefit of including strep pneumoniae, MCAT, and H flu on a pharyngitis panel?
We see that these are very common respiratory bacteria, some of them associated with sore throat. Identifying the cause of the patient's symptom is always going to help the patient understand what's going on with themselves. Interpreting these respiratory bacteria is really going to be important in the context of what else is detected in that patient, because they may just be normal flora. So there are other respiratory viruses detected or group A strep in a pharyngitis patient. It's more likely that those are associated with the patient's symptoms. But there are some cases where maybe strep pneumo or MCAT might be associated with sore throat. Interpretation and context is really going to be important for them.
Janie, in those scenarios, the interpretation, would you base that based on the level that you're seeing in that patient, or can those be at a pathogenic level and still be colonizers?
So we do see that some bacteria like strep pneumo can be present even at high levels in the nasopharynx of children especially, but microbial load is going to be something that you'll want to keep in mind. As the higher the microbial load, the more likely a bacteria is associated with pathogenic outcomes in the patient's symptoms. But most important is going to be, is the pathogen almost always pathogenic? Is it sometimes normal flora? That'll be the first step to interpreting reports.
Excellent. Thank you very much. A few wrap-up points. Janie, why don't you walk us through your thoughts on the wrap-up points and read them out to us real quick.
We mentioned this a few times, but the negative predictive value and the positive predictive value of rapid antigen tests is going to be dependent on community prevalence. using resources that are publicly available, such as virus circulation patterns published by the CDC. Additionally, HealthTracks does publish positivity reports on their website available to the public. These can be a great starting point for understanding what's circulating right now in the community. And rapid diagnostics in general are going to be valuable in reducing patient anxiety, improving patient outcomes, and preventing the overuse of anti-infectives, as we know that antimicrobial resistance is of increasing concern globally. So we want to be good antibiotic stewards. Last but not least, the rapid clinically actionable PCR can be a technique that allows testing for multiple types of pathogens from a single sample. So in situations or cases like the pharyngitis patient that we just talked about, being able to test for both group A strep and respiratory viruses is not only a tool for identifying streptococcal pharyngitis that needs antibiotic treatment, but it's also a tool for identifying viruses so the patient can understand that an antibiotic might not change their outcome. These are really just different helpful points to keep in mind as you go through respiratory season.
Very good. Dr. Goldberg, one of the takeaways that kind of comes through in these cases today is the importance of speed and the ability to get accurate diagnosis in these patients and be able to make that don't treat decision as soon as possible so they can get healthier faster. What are kind of the things you look at from a clinician standpoint on when do you say, okay, I want to do that rapid PCR because I can now get answers back the next morning? When do you pull that trigger and what makes you comfortable? And when do you say, hey, I'm going to use some diagnostic stewardship here and not do a test versus do the test?
Yeah, Ben, three considerations. So in someone that's elderly, they're not going to show the signs and symptoms that necessarily affect how ill they are. So I want to get that diagnosis right, and I want to get it fast. First case. The second would be in someone who I am concerned that I have to start a therapy to impact a sequela, long COVID, bad COVID, group A strep, seeding a valve, or a kidney. I want to get that right, and I want to get it done timely. Now, our cases, folks presented within a day, that was an opportunity. But if they were presenting day 3, day 4, the clock is really ticking quickly. And then finally, what I'll add is you really want to do evidence-based practice, have a method that you're using to evaluate these cases, but then look at each individual scenario and points such as where people are living. Are they going to be lost to follow-up? Are any of their health conditions out of control? And then the epidemiologic considerations that Dr. French highlighted are all important elements for decision-making.
Excellent. Thank you both. Thank you to everybody in the audience for joining us for this Urgent Care Association Solutions on Demand webinar brought to you by HealthTrack RX.